Hello, I'm Bethany Samuelson Bannow. I am the Deputy Editor of ASH Clinical News, and we are here on site at ASH 2025 in sunny Orlando, Florida. And today I have with me the wonderful Dr. Gloria Gerber, who is an assistant professor at Johns Hopkins University and an expert in PNH. And she's going to be giving us her insights on 3 of the abstracts presented here at ASH. So welcome, Dr. Gerber. Thank you for being here.
Thanks for having me, and thanks for your time and the opportunity to share these my insights and discuss these abstracts and highlight some exciting new work in PNH.
Yeah, it's great to see some new treatments on the horizon. So we're going to start with abstract 318, looking at VSA012, which is an siRNA targeted against complement factor B. And this was an interim analysis from a phase 1b study, so some fairly new and emerging data, but would love to hear your take on this particular molecule and how it differs from what is out there and why that might be advantageous to patients.
Yeah, I think of all the potential new PNH treatments on the horizon, this is the most exciting to me because frankly, it's a completely different mechanism of action. So this is, as you said, an siRNA that specifically targets liver-specific production of factor B, and most of our complement proteins, with the exception of factor H, are primarily made in the liver. So this will reduce factor B levels and thus inhibit alternative pathway activity, ideally. So we do, as you know, have iptacopan, which is an oral factor B inhibitor that's clinically available since 2003, so actually 2 years now. And that's an oral option, which is available twice daily. So this is a subcutaneous injection. And in this specific study, they just gave the loading dose, so at time point 0 and about a month later. And they used 2 different dosing mechanisms and showed, especially in the higher dose, pretty good sustained depression of factor B levels, alternative pathway activity, and LDH at least through 12 to 16 weeks. So the data is very early, but I think what's exciting about this is the dosing in these schema are every 6 months after the loading. So again, most of, if you think of ravulizumab, which is the complement terminal pathway complement C5 inhibitor, that's dosed every 2 months or about every 8 weeks after the loading dose in steady state. So we could have an option that's dosed again every 6 months. So I think that's incredibly exciting for PNH patients, as the data accrues and if we see the efficacy and safety data mature. So again, it's a completely different novel way of targeting factor B and potentially a very long half-life product. The other thing I think that concerns PNH clinicians or people who treat PNH is compliance. So with the oral inhibitors, one of the number one things I'm thinking about with my patient is how well do I know them and how compliant are they going to be? So you have to keep in mind that the median age of diagnosis in PNH is in the 30s. So this is a lifelong disease diagnosed in young people. And I don't know about you, but I'll tell you, when I personally have to take a pill, let's say an antibiotic for a short period of time, if I'm taking even a twice-a-day drug, and this gives me a lot more sympathy for my patients, frankly, I can't say I'm perfect about it. You probably don't have to be exactly perfect, but I don't think we know completely the effects of missed doses and how many missed doses you can have, or if you have a complement amplifying condition like a stomach virus, both you can't keep down your medicine and you have an infection, so you're revving up that complement system. You're at a high potential for breakthrough hemolysis. But if you have this agent that's on board where you're not dependent upon oral absorption or patient compliance factors, I think that becomes less of a concern. Now, with any complement inhibitor, you can still have breakthrough, and we don't have enough data here to talk about that, but I would anticipate in the setting of a strong complement amplifying condition, you could still, like an infection, a surgery, whatnot, you could still get pharmacodynamic breakthrough hemolysis on any of the agents, but I guess we don't know that yet, depending on how well factor B is suppressed. But the alternative pathway is an amplification loop, and you can get complement paroxysms or triggered through any of the pathways. So I think, how this agent will affect, breakthrough hemolysis, which might be in a patient who's well controlled every couple of years, is still to be seen. If there is a potential for thrombosis, and of course, infection, which is what we get most concerned about as the most serious side effect on these inhibitors. And we don't have a lot of data there. I think there was one.
All right, well, thank you for joining us today for our discussions with the wonderful Dr. Gerber. And you can look forward to more insights on ASH 2025 on our website, as well as in our January edition of ASH Clinical News. Thanks for joining us.